Hello and welcome to Integrated Spectrum of Health Functional Medicine membership. And we're going to go over today a quick clinical topic and talk about the thyroid gland. My name is Lynn Jocelyn. I'm a functional medicine physician assistant, and we'll go ahead and get started. My mission is to empower people to optimize health through a functional medicine and colorful approach so that you can embody your birthright of vitality, connection, and joy, live your life on purpose, and harness the healing connection through community. So let's get started. What is the thyroid gland? So the thyroid gland can be thought of as a thermostat to regulate energy for the entire body. The thyroid gland has an impact on every cell and every organ system of the body, from your mood to your menstrual cycles, metabolism, hormone regulation, weight loss, weight gain, and so much more. It truly does impact all of our cells. So where is it located? It's located at the front part of your neck. It's shaped like a butterfly, and it's about midway between your chin and the base of your neck here. And typically, in a healthy thyroid, you can't feel it, but some things that can affect the thyroid will cause it to swell or get nodules on it, and that's why we will always check during physical exam. The thyroid hormones, the hormones that are produced from the thyroid gland, mainly T4 and T3, truly are the master regulators of metabolism. And this is a really busy slide, but if you look at this, the thyroid gland here is kicking out T3, T4, and it's impacting all these different biochemical processes in the body. There can be different kinds of dysfunction of the thyroid gland. The most common dysfunction we see is hypothyroidism. That means underactive thyroid gland or underfunctioning. And usually with this, you'll notice the energy is slowed, metabolism are lower. When the thyroid gland is overactive, it's called hyperthyroidism, and this is an overfunctioning. Things are running in overdrive. People typically feel anxious. They may have a racing heart. They may be losing weight. They can't keep weight on. Now, the thyroid can be affected by an autoimmune disease, and there's an autoimmune disease that can cause hypothyroidism called Hashimotos, and an autoimmune disease that can cause hyperthyroidism that's called Graves' disease. About 90% of the diagnosed hypothyroidism in our society is caused by Hashimotos. And traditionally, in conventional medicine, we don't always distinguish, is it Hashimoto's or not? And I'm going to hopefully talk to you today in today's presentation as to why that's important. Because we really treat it differently than a functional hypothyroidism, which is just in the gland. Other causes that can affect your thyroid are nutritional deficiencies, infection, and inflammation. So today, we're going to focus mostly on hypothyroidism. The symptoms of hypothyroidism is people may complain of really dry or brittle hair and nails. This one's always interesting. The loss of the outer third of the eyebrow hair, puffy face, maybe an enlarged thyroid, heartbeat can be slower, inflammation can lead to arthritis, cold intolerance, depressed mood, dry skin, fatigue, forgetfulness. There may be some menstrual disorders or irregularities, infertility, muscle aches, weight gain, constipation, and brittle nails. As you can see, if you think about that, just take a look at that slide. Every cell of the body is affected by thyroid dysfunction. And interestingly, up here, it says only 10% of the people that have hypothyroidism actually have overt symptoms. And unfortunately, if you look at these symptoms, a lot of these can be subtle or vague, right? They could lead to many different things. So the importance of checking and testing for hypothyroidism in an adequate way is really important to support people living with many of these symptoms. So here's another way to look at the impact of thyroid hormone deficiency. Remember, today we are talking about hypothyroidism. And so there's hypothyroidism and the peripheral thyroid hormone activation of the cells. So what happens, we're going to get to a better slide, but the thyroid gland kicks out what we call T4, thyroid T4. And then T4 needs to be converted into T3, which is the active form. And then T3 impacts the brain, gastrointestinal, bone, muscle, metabolism, vascular system, and immune system. So all aspects of the body. Now, conventionally, and both models are really important when we're taking care of people with hypothyroidism. And today I'm going to hopefully let you know or explain to you why expanding on the conventional both diagnosis and treatment of hypothyroidism is important and will support a person just having a better quality of life and more vitality. So looking at the conventional model of hypothyroidism, we typically test one lab test called TSH. TSH is actually from the brain. So we have our hypothalamus signals the pituitary to kick out TSH, and it's called thyroid stimulating hormone. Thyroid stimulating hormone goes to the thyroid gland and tells the thyroid gland we need more thyroid hormone. So it kicks out thyroid hormone. Now, if the TSH, it's a feedback system, so if this TSH is high, we know that there's not enough thyroid because the body's like, the thyroid hormone's too low, you better make more. And so when we look and test thyroid hormone only, we find out it's high. They get a positive diagnosis of hypothyroidism. Conventional model will give you a replacement of thyroid hormone, which is actually a very important step. But what is missed is we don't have all the other lab parameters to find out, is this Hashimoto's? Is this an autoimmune thyroiditis? What's happening to the active form, the T3, out in the peripheral, the body tissues? And so a lot of times what happens is people have a high TSH, it's positive, they're diagnosed with hypothyroidism, they're prescribed thyroid replacement. For a short period of time, 3 weeks to 3 months to 9 months, they actually feel better, right? Because that's meeting their needs. But the immune system has never been addressed. And so the autoimmune, where the body beats up on the thyroid gland, that process continues and the thyroid gland continues to be destructive. So their symptoms come back often and TSH continues to rise. So we need to increase the replacement of the thyroid medication. So yes, that is part of the treatment, but we need more because in the conventional model only, oftentimes the other symptoms of depression, anxiety, menstrual irregularities are then given another medication to support those. Whereas if we actually treated the immune response, the beating up of the thyroid, these other symptoms could be supported and perhaps not needing the other medications. So this is a great schematic that talks about, this came from the European Society of Endocrinology, a great paper, and it talks about the progress of thyroid dysfunction. So if you look over here at stage 1, your TSH is normal, your free T4 is normal, your TPO antibody, which is one of the antibodies that we test for looking for autoimmune disease, is normal. Right? So everything seems to be functioning okay. We move over here to stage 2. TSH is normal, free T4 is normal, but the TPO antibody begins to be positive. Now, in this stage, people may or may not have any symptoms. Why is it important? Because the presence of an antibody beating up on itself tells me that if we don't address the immune system, or this person becomes under a ton of stress, trauma, toxicity, their immune system can be activated for other reasons, and this TPO antibody can get worse, and the beating up on the thyroid gland can progress, and then they begin to progress into stage 3. TSH is positive. Free T4 may or may not be any different, but now we're beginning to have likely symptoms through here. And then we move into stage 4, and that's when antibodies are positive. We're having peripheral hormone, thyroid hormone is lower, and TSH is high. So if we could work in this early stage, when the antibodies become positive and really support the immune system, perhaps we could slow the progression to overt symptoms of hypothyroidism. These are the tests. I want to kind of go over the lab tests. This is a couple things are important about this slide. These are the tests that I typically recommend, and there's 2 more. No, actually, there's 1 more. So in the conventional system, typically only TSH is drawn. But if we don't have the rest of these, we don't have the full picture. So when I see somebody and I think there's a thyroid issue going on, I will run a TSH, a total T3, total T4, free T4, free T3, reverse T3, and antibodies for TPO. I also run another antibody for thyroglobulin. The other important thing about this chart is we have standard reference range and optimal range. The optimal range is a tighter range that we really want the thyroid gland and the labs to be in these tighter ranges to prevent further destruction or disease of the thyroid and, honestly, quality of life. So these are the standard reference range that you see on a standard conventional lab. These are the optimal ranges that I look through for a functional look into thyroid health. This is a great infographic. It talks about taking command of your thyroid. And I just love, this is Dr. Lara Salyer's work to really simplify this. So let's go back to the basics. Think about your brain. That's the boss. That's telling the body what to do. The pituitary kicks out TSH, thyroid stimulating hormone, goes to, this is the thyroid gland here, and it tells the thyroid gland we need thyroid hormone. So it produces T4. These things, vitamin E, B2, B3, B6, vitamin C, D, iron, iodine, tyrosine, and zinc are all important in the process of actually producing thyroid T4 hormone. And that's considered the paycheck, right? So when you get a paycheck, it's literally just a piece of paper, and you can't go into the grocery store with your paycheck and pay for groceries. Right? You need to actually cash that. So that's the difference. If we only have T4 in our body, none of those metabolic processes that we need to work, remember all the cells in the body that it affects, cannot happen. They need to be activated by T3. So T3 is considered the cash. Now, how does T4 turn into T3? It needs zinc and selenium. And this happens outside of the thyroid gland in what we call the peripheral tissues. So this is the cash. This is the stuff we can actually work with. There's the percentage of active T3 is actually very low compared to T4 because we use it on demand when we need it. Now, another thing to know is when you think of your paycheck, you get a certain amount of cash, but then there's deductions, right? There's things that go to the IRS. There's things that maybe you put into your healthcare savings, right? So a portion of your total pay doesn't actually go as cash. And this becomes, in the analogy of the body, the deductions are stress, toxins, pregnancy, inflammation, low-calorie diet, and medications can all take more away from the ability to be free cash. And that's called your reverse T3. And that causes, what happens is the reverse T3 competes for the receptors of where the free T3 would bind on the periphery of the body. So if you can't have that active T3 binding and reverse T3 binds instead, it puts on the brakes and it stops that reaction. So it's an important thing to evaluate when looking at the function of your thyroid gland. Okay, another way to look at this, which I love this all the schematic as well. Simplifies it a bit more. So here we go. This is just the thyroid gland. T4 comes out. T4 then is, some of it goes to reverse T3 and some of it goes to the active T3. Both of these are competing. This is a receptor on a cell in the body. Could be any cell. Could be a brain cell, a liver cell, a muscle cell, something that's needing metabolism. So they bind to that. Now they're competing. So if you look over here, factors that contribute to proper production of thyroid hormones. So even for the thyroid gland itself to produce enough T4, we need these nutrients. Things like iron, iodine, tyrosine, zinc, selenium, vitamin E, and your B vitamins. Then we need support to converting T4 to T3. This is the selenium and zinc that happens in the periphery, in the tissues outside of the thyroid gland. These over here are the things that inhibit. So stress, infection, trauma, radiation, medications, fluoride, all these things inhibit the thyroid gland from making T4. What increases the reverse T3, the T4 to go to reverse T3 are these things as well. Stress, trauma, low-calorie diet, inflammation, toxins, infection, liver and kidney dysfunction, and certain medications. So what this tells us is you have agency to support your body, working on lowering these factors in the red and increasing these factors in the blue to help your thyroid function. Okay, so just again wanted to show you the lab values again after seeing this. These are the things we're able to test. Okay, one more schematic I want to go over. TSH comes from the brain, tells the thyroid gland to kick out T4. T4 is protein bound. What that means is it's driving around the blood in a bus, right? In that bus, T4 alone can't do anything. It needs to be converted to T3 and then even further converted to free T3. Free T3 is what binds to the receptor on the tissue or the cell to have its metabolic activity. Also, really important here, T4 is 90% of the thyroid hormone that comes out of the thyroid gland is in the form of T4. Not a lot of it is T3. So T4 has to be converted to T3, and it's done so by this enzyme called 5-deiodinase. Now, certain things can downregulate or slow this biochemical process. Excessive high cortisol, stress, trauma, inflammation, all those things slow this process. So if you have a lot of T4, but you can't get it to the active form, you're still going to have a lot of symptoms of hypothyroidism. Now, one other thing I want to point out, and it gets a little confusing, so I want to try to do it super clearly. 90% of the thyroid hormone that comes from the thyroid gland is in the form of T4. We also know that the majority of the thyroid hormone that feeds back to tell the brain we've got enough, slow down from making it, is in the form of T4. So think about this. If we're only testing TSH and we find that TSH is high, so that tells us that T4 is low, and we stop there, we give you thyroid hormone in the form of T4, but the problem is actually out in the periphery and not enough is getting to the active T3, you're still going to feel really poorly. Right? Does that make sense? Yeah, and we'll go over it again. So conversion of inactive T4, remember it's not active, to active T3 in certain tissues. This happens the most in the liver. The gut is the next highest, and then all the other peripheral tissues, which means, for instance, if you had a damaged liver, that would affect how well you're converting to the active form of T3 and would affect how well you're feeling and your treatment of hypothyroidism. So This is just so much bigger than the thyroid gland. It's all the tissues working together. So again, conventional model of hypothyroidism typically tests the TSH. If it's positive, diagnosed with hypothyroidism, we do thyroid replacement until TSH is normalized. But this doesn't often take care of all the other symptoms that are caused by immune system dysregulation and autoimmune and beating up of the thyroid gland. The other thing that's really important to note, unfortunately, when the body is beating up on itself, and in this instance, it's autoimmune disease of the thyroid gland. When that's happening, the thyroid tissue gets destructed. And sometimes when those follicular cells get destructed and break up, they actually dump out thyroid hormone. So people early as this disease is progressing can have big fluctuations of their TSH, right? Because if you're you're dumping a ton of thyroid hormone, your TSH is going to be lower. And if you're dumping out just a little, your TSH is going to be higher. So if you're disrupting the thyroid hormone cell or the thyroid gland cells, and that's causing a dumping, people in the early stage may have symptoms of hyperthyroidism and then hypo. So they'll do a fluctuation. So when you only get one test a year, what if we caught it here? What if we even did it every 6 months? We caught it here, here, and here. But we didn't catch these highs and lows. We would not know that you're having thyroid dysfunction. Again, even more important to check the whole thyroid hormone picture. So again, and early on in diagnosing people with Hashimoto's, one of the first things that we do to support them is to help them find that stability of their TSH levels. They have Hashimoto's, so you have autoimmune disorder. Once your body beats up on a tissue, that autoantibody is always going to be there. Now, we can support your immune system so it's less reactive, so you have less symptoms. And one of the ways to do that is to try to get stability here. And it is a very complicated web in the early stage, and we look at all the body systems to help bring you into balance to have less symptoms. 90% of hypothyroidism is caused by Hashimoto's autoimmune disease. This is a busy slide. I'm not going to go into all the nuances of this, but this is the pathophysiology of Hashimoto's. Remember, Hashimoto's is autoimmune disease of the thyroid gland causing hypofunction, hypothyroidism. And that actually starts in the immune system. The immune system gets dysregulated and begins to beat up on the thyroid gland. And it kicks out autoantibodies. Those autoantibodies can actually cross-react with the cerebellum in our brain and cause neuroinflammation. They can cause blood-brain barrier permeability, things to get into our brain that we don't want to. Certain genetic susceptibility are at higher risk for Hashimoto's, and this is the HLA-DQ, which is also people who have celiac. So if you have celiac disease, you're at higher risk of Hashimoto's. So you'd be somebody I would want to check antibodies in regularly. So this is a convoluted web to say that there's a lot of things going on. So only treating with thyroid replacement will not get you to symptom relief. Okay, this is talking about the any hormone in our body follows this this basic simple idea. Hormone is produced in the body. Then they have to travel on a bus. We call that a globulin or a protein. And when that hormone is connected to the bus or the protein, it's not active, can't do anything, just drives around. So then we have to have a biochemical reaction that releases that free hormone from the bus, and then the hormone can bind to the cell. But guess what? There's still another caveat. these receptors on the cell need to be sensitive. If you know, you've heard the term insulin resistance, well, you can have the same thing with thyroid hormone. You have a happy, free T3 ready to bind, but this receptor is resistant to it. So you don't get the metabolic change that you need, and you still may feel hypothyroidism. And then we get rid of our hormones. So produced, travel in the bus, get released from the bus, hopefully bind to the receptor, and then we need to get rid of them through our phase 2 detoxification in the body. So this is just, let's see, interesting. Thyroid binding globulin, so the bus that thyroid hormone binds to, is considered to be an acute phase reactant, which means when the body's under stress or inflammation, the binding globulin goes up. What happens when there's more binding globulin? More thyroid hormone is bound to that, and when it's bound, it cannot be used for active hormone, right? So just by nature of being inflamed and under stress, you're holding on tighter to your hormones. Also, elevated estrogen have been shown to elevate your thyroid binding globulins. You have more buses, you have less free hormone. Birth control has also been shown to elevate thyroid binding globulin. So more buses, more bound hormone, less available for activity. All right, now I'm going to go through these next slides pretty quickly. But when I see somebody for Hashimoto's, I am thinking about the web of triggers that may have an effect on the immune system and potential for turning on autoimmunity to the thyroid gland. So we look at dietary triggers. So this is after the Hashimoto's genes are turned on. Remember in that silent stage? You have positive antibodies, but you don't have symptoms or abnormal labs yet. These are all the things you would want to really hone in on so it doesn't progress. Lifestyle triggers, Hashimoto's genes are turned on, no peripheral symptoms yet, insomnia, sedentary lifestyle, overtraining, smoking, alcohol, drug use. So are these starting to sound familiar? All these lifestyle events help decrease the reactivity of your immune system. Certain pathogens can trigger, once the genes are turned on, for it moving into overt hypothyroidism. H. pylori, yeast, hepatitis C, Epstein-Barr virus, like all of these. And then certain chemical triggers, BPA, pesticides, air pollution, mercury, all sorts of things. So we're getting to the end here. So thyroid hormones and environmental lifestyle factors. This is what I just said, but puts it in a different schematic. We've got certain toxins inhibit the actual production of the thyroid hormone. Certain traumas, medications, stress or infections decreases, so it does two things. It decreases the conversion of T4 to T3, and it increases the conversion of T4 to reverse T3, putting the brakes on. Okay? And then certain nutrients that affect each of these biochemical processes. B vitamins, iron, vitamin E, vitamin C, tyrosine, vitamin D, B3, vitamin B12, selenium, zinc, and vitamin A. So that was a lot of information, and I hope now that you have a better understanding of Hashimoto's, of hypothyroidism, and the thyroid gland in general. And if you're having any of these symptoms and want to dive deeper, I look forward to visiting further with you, and I hope you have a great day.